So Douglas, what else do you do as far as your assessments?
Well, I think it's just important to note that how we define severity, which you have to in order to run clinical trials. You have to have benchmarks that you set, ranges that you set to define severity. Is not necessarily how the patient defines severity. And we do have trials that show that. So, I mean, just so we have some definitions for our colleagues, I mean, if we're going to look at body surface area, and 1% body surface area is one palm, right? You know, and so, you know, if you can cover 5 spots with your palm, then they have a 5% body surface area. And so we have these defined things. If it's greater than 10%, it's considered severe, you know, for trial purposes. But if the one palm and that palm just covers the top of the scalp or covers the genital area, that could be only 2%, but still be significantly severe to the quality of life that the person has. And so I think that with initiating therapy, we have to think about not just what are the parameters of the physician global assessment, PGA, or BSA, but where is that located and how does it impact their lives? Because while we've got some recommendations that are published, I mean, earlier in 2019, the AAD put out some guidelines, and they have more of them that are forthcoming early part of the year on looking at comorbidities and how to stratify. And then we know that the National Psoriasis Foundation now has guidelines that they put out a year or so ago telling us, recommending which ones to use first versus second. But, you know, the more recent guidelines which came out just this last early fall, late summer by the International Psoriasis Council, the IPC, I like the way that they categorize things. I don't know if that classification will take traction or not, but they basically just lump patients into 2 categories, either those who should receive topical or those who should receive systemic. Yeah. Because what they are recognizing, and this is a group of over 100 dermatologists that are global, that are putting in these recommendations, what they're recognizing is that just using PASI scores, you know, which trials use, and just using PSA, it overlooks 3 things. It overlooks the past medical history of the patient, if they've been on previous treatment. It overlooks the sensitive areas where the BSA is distributed. And it also overlooks the quality of life and how the disease impacts the person. So basically, if your BSA is greater than 10%, right, if it's in any highly sensitive areas, or if there's a tremendous burden on the quality of life of the person, then that would be, all of those would be a candidate for systemic therapies, which they define as either phototherapy, biologics, or orals. And if it's less, then topicals could be an initiating step to see how it works. Now, we know that topicals are grossly overused, and people stay on them for much longer when they should be shifted to things that can manage their disease. But I like the idea of just looking at, hey, and I think these guidelines will get patients on treatment sooner, and will help us get things approved for insurance companies as well. They're the ones that make us step through so many hoops before we can finally land on the treatment that we know is going to clear them and improve their quality of life.
And the older thought process, 20 years ago, we had what we called stair-step therapy, which was that you had to start with certain things and show that they did not work before you could move on to the next therapy. And part of that was to get insurance approval. But I really feel like that we all as NPs and PAs need to understand you don't have to do that anymore. In fact, I think it's contraindicated based on the knowledge that we have, the science that has shown us that a person who has different aspects of disease or severity of disease or psychosocial impact, you have the opportunity to access some of these therapies. Now, in clinical trials, for a biologic to be approved, the FDA sets a standard that the trials have to be done in people who have 10% body surface area or more and a 12 PASI score. So PASIs being an assessment tool that we use that just tries to put a numeric value to the thickness, scaliness, erythema, and the amount of their body that's covered. But as we mentioned before, the labeling will be from moderate to severe plaque-type psoriasis. So that means moderate means 3%. So if you look at the definition and say, well, my person has 3%, and sometimes, again, we have one therapy that has on their label that as little as 1% body surface area makes them a candidate for psoriatic treatment, for biologic treatment. And I think just because a person has 1 or 2 or 3%, where is a good place to have 1% body surface area of psoriasis? Where would be a good place that it would be acceptable? And sometimes,
not one.
I can't find
not one.
Not in dermatology,
Yeah,
when they don't want one big pimple somewhere where they don't want it. And I think that the main thing you have to think about is don't prejudge a patient to say you're not a candidate because you don't have enough body surface area, because you have to think about all of your patients being affected by this disease in some way. Rarely will you have a patient who says, it doesn't bother me at all. It doesn't itch, it doesn't bleed, it really doesn't bother me. That will be an incredibly rare experience in your clinical practice. Most of the time, they are going to have things that bother them about the disease, which they may or may not communicate to you. And then there's going to be a lot about the disease that bothers you as a clinician, because you know what can happen. You know you have to assess for multiple other factors. And you're constantly ducking and jiving, trying to figure out what therapy is going to be best for them, where do I get them started, and how do I keep them moving across their lifespan so that we have minimal impact from the disease.